Thank you so much, judges and chairperson. So I'll be sharing our experience on safety and efficacy of 27 gauge lens sparing vitrectomy for stage 4 ROP. I have no financial disclosures. So lens sparing vitrectomy has been established as the standard of care for stage 4 ROP. It started with Dr. Mike Tracy introducing with the 20 gauge systems and 2 ports doing the vitrectomy, but now majority of studies have reported with 23 and 25 gauge very good results up to 70 to 80%. There are only 2 studies available for 27 gauge use in lens sparing vitrectomy from Japan and one from southern India with a very few number of eyes. 27 gauge has potential advantages as it has smaller incisions, better sealing. It's a smaller eye, so that is of great importance. The size is of great importance here. Maybe with the smaller incisions, lesser chances of post-op hypotony and bleeding. That is a major issue in these eyes. And better dissection of the proliferation in ROP because of this cutter tip being closer to the retinal surface. And obviously faster entry and closure time. These are potential advantages that we had in mind to try out. So the idea was to evaluate the safety and efficacy of the 27 gauge LSV. It was a retrospective interventional case series. All patients who underwent LSV 27 gauge for stage 4 ROP between September 2019 and 20 were recruited. Detailed preoperative and intraoperative data recording was already done using standardized performa as a standard done for all the surgeries, and there was a minimum postoperative follow-up of 3 months. So this is the detailed performa that we normally use for our surgical data. It has very detailed preoperative features as well as the intraoperative features, all the complications that can potentially occur to record those as well as the surgical times. So the primary outcome measure was single surgery anatomical success rate at 3 months, and the secondary measures were the iatrogenic complications, wound leakage, secondary loose blood, and the surgical times that took. So this is just a representative case of a 8-week-old infant who presented to us at 8 weeks, 40 weeks post-menstrual age, 1600 grams. And you can see the right eye stage 4B ROP lifting up to the crystalline lens, and the left eye stage 4A. So laser was done in this case, as is for most of these cases prior to surgery, and a week later was taken up for right eye lens sparing vitrectomy. These are just a standard of what we normally do in these eyes. We enter at about 1 to 1.5 millimeter through the pars plicatum. The entry is more vertical, and I think this will make you realize how limited space we have to work in these eyes, especially when we are trying to go beyond the limbus. And once all the 3 ports are in, you can see these ports are still budging along the lid margin. So very limited space, and 27 gauge does help a little bit in that. And you can see the detachment that is touching the crystalline lens. So the idea of ROP surgery is not an extensive surgery. It is to cut the vector forces, the disc to the lens traction, the disc to the ridge, and ridge to periphery. You just have to cut these planes and debulk the vitreous as much as possible. Hyaloid removal or any other thing is not an objective, and preventing a break from happening is of prime importance, because once a break happens, you are done with the surgery. So just this, and then we close with a partial fluid air exchange. The fluid air exchange is primarily to tamponade these scleral ports and not for any other purpose. And then in majority of the cases we leave them sutureless, and we check for leakage at the end of surgery. So this is the outcome in this case at 20 days post-operative. You can see the right eye, the detachment has collapsed, and it gets better from here on. The left eye regressed with laser alone. So 27 gauge, initially we had a big problem with the flexibility of the instrument, especially dissecting in the periphery. But with the 27 plus, so this is the Constellation system that we were using. I have no financial interest. They've introduced this extra 1 millimeter sleeve over here, which kind of stiffens that instrument and reduces the bending issue. So we found that 27 plus had greater advantage than 27. We used both in this study. So we had 44 eyes of 31 infants. 10 infants underwent immediate sequential bilateral lens sparing vitrectomy in the same setting. And the mean post-menstrual age at the time of surgery was 42 weeks. So majority of them were being operated right when they were to be born. Stage 4B accounted for about 40% of the cases, and 60% was stage 4A. Almost all eyes received laser prior to surgery. Anti-VEGF was given in 18 eyes. 11 of these was as part of the primary treatment of ROP, and 7 were given preoperatively, seeing the vascular activity in the eyes to reduce the vascular activity. And in those eyes, in 7 eyes, the average time was 4.7 days. Vitreous hemorrhage was already present in 25% as well as pre-retinal bleed. The fibrovascular proliferation was equally distributed between less than 6 and more than 6 clock hours, about 50%. On the outcome, 41 eyes had a minimum follow-up of 3 months and 73% of them had a favorable outcome. Vitrectomy could be done with 27 gauge in all the cases. The factors causing unfavorable outcome, statistically important, were lower gestational age, less than 28 weeks, and a higher stage at diagnosis, which is kind of expected. And the average procedure times was about half an hour for the total procedure and about 18 minutes for the vitrectomy. The closure time had a higher range, as you can see, because wound leak and suturing the port sometimes takes more time. And complications were lens touch, post-operative fresh bleed, posterior hyaloid contracture, resurgery in 5 cases, and cataract, which all underwent subsequent cataract surgery. Very important point here that for loose blood in the eyes which received anti-VEGF, none of them had post-operative loose blood. So this was a very interesting finding that we found. We didn't realize that while doing these procedures. So to conclude, advanced cases of ROP can be successfully managed with lens-sparing vitrectomy, and 27 gauge lens-sparing vitrectomy appears safe and effective in the management of stage 4 ROP. A comparison would be in the other gauges would be the next step. Thank you.
Good presentation.
Thank you, ma'am.
Paper, I've used 25 gauge. That itself has bending, so 27 is definitely.
I think they've introduced 25 plus and 27 plus, both of them, and that 1 millimeter sleeve really made a difference. They have increased the cut rate also. That didn't matter much, but that sleeve was very important.
So you're
and
saying
we
that
realized that retrospect. We asked the company people that what's different in your 10,000 cutter, that it's not bending, and that 7,500 cuts was bending. So then they asked their company people, and then they brought out that pamphlet, okay, this is there. And then we examined it under the microscope and actually saw that extra sleeve. So that has an advantage.
So you had that advantage of having that extra sleeve.
Yes, ma'am.
27 plus has that extra
27 plus. So this study we used both, but it was during this time that we realized that yes, the 10,000 cutters were functioning better for us ergonomically while operating. So
but
that is the major issue with 27.
With kids, the vitreous is more, the vitreous is more bulky or more
So
thick.
that is,
so 27 gauge is
so
good.
the surgical times that I showed, sir, they are comparable to some of the papers that are available for 23 and 25.
Okay.
We couldn't do a head-on comparison here, but we are planning that prospectively.
Yeah.
Sure. Great.
Okay.
Thank you.